Assalamu alaikum wa rahmatullahi wa barakatuh. We will discuss today the malignant skin lesion as a continuation of the previous lecture, the skin and subcutaneous lesions. We stopped at the benign lesions of the skin and subcutaneous tissue, lipoma, the last type of these lesions. Today, inshallah, we will continue with the malignant skin lesions. As we said in the last lecture, the skin is formed of three layers: the epidermis, which is formed of stratified squamous epithelium. Stratified squamous epithelium is formed of multiple layers, and the main layer is the polyhedral cells and the basal layer. The brachial cell layer is the polyhedral cells, which is drive the squamous cell carcinoma, while the basal layer give the basal cell carcinoma, so it's named basal. And the melanocytes, which presents as the basal layer of the epidermis, give the melanoma. This is the main three types of malignant skin lesions. So we have squamous cell carcinoma, rising from the polyhedral cells of stratified squamous epithelium, which is called the brachial cell layer, and the basal cell carcinoma, which is derived from the basal layer of the stratified squamous epithelium, and melanoma, which is derived from the melanocytes. Then the dermis, which is formed of connective tissue. This connective tissue containing sweat glands, sebaceous glands, nerves, vessels, and each part of this dermis may give to the types of malignancy. The dermis itself may give dermatofibrosarcoma protuberans. The sebaceous glands may give sebaceous adenocarcinoma, cutaneous nerves neurofibrosarcoma, vessels hemangiosarcoma, cutaneous lymphatics lymphangiosarcoma, and the deep layer, which is called the hypodermis, which is actually the subcutaneous tissue, may give rise to the liposarcoma. This is the malignant lesions of the skin and subcutaneous tissues. We have three main common malignancies of the skin and subcutaneous tissue, which is the squamous cell carcinoma, basal cell carcinoma, and melanoma. We will start with the basal cell carcinoma. Basal cell carcinoma, or rodent ulcer, as we said, it's a tumor of the basal layer of the stratified squamous epithelium. It's called locally malignant tumor. What's the meaning of locally malignant tumor? It's a malignant tumor but doesn't give distant metastasis. We have some locally malignant tumors in surgery, like basal cell carcinoma, adamantinoma, which is a tumor of the mandible, pleomorphic adenoma, which is a locally malignant tumor. So the basal cell carcinoma is a locally malignant tumor. This locally malignant tumor raises on the skin in any side of the skin, but specifically in the sepiroic area, which includes the nasolabial folds around the eye and the hairline, as we see in this picture. This picture showing the common site of the basal cell carcinoma, which is called the sepiroic area. It extending from the outer side of the lip till the lobule of the ear. It's called the sepiroic area, which is the site of the basal cell carcinoma. As we see in the picture in the right side, the basal cell carcinoma at the nasolabial fold in an old age person. We have some types of the basal cell carcinoma. The commonest two types of the basal cell carcinoma is the nodular subtype. The nodular subtype is a nodule which has a superficial dilated vessels. This nodule is the earliest lesion of the basal cell carcinoma. Later on, this nodule ulcerate and give the characteristic ulcer of the basal cell carcinoma, which is called the rodent ulcer. The rodent ulcer is derived from the eating, because the basal cell carcinoma extended deeply and extensively in the deeper tissues and destruct it. It may destruct the bone, eat the deep tissue. So it's called the rodent ulcer. The rodent ulcer has a specific characteristics which have a rolled in beaded edges. Rolled in rolled in. The edges of the ulcer are rolled inside the ulcer, not raised everted edges like the other types of the squamous cell carcinoma, malignant ulcers like the squamous cell carcinoma, and beaded edges from fibrosis. This rolled in beaded edges due to the rate of healing of the basal cell carcinoma is more than the rate of growth of the malignancy. So the rate of the healing is more than the rate of growth of this malignancy, give the characteristic rolled in beaded edges of the ulcer. As we see in this picture also, the basal cell carcinoma around the eye, which is the commonest site of the basal cell carcinoma over the seborrheic area. What is the microscopic picture of the basal cell carcinoma? Basal cell carcinoma have a characteristic microscopic picture. This characteristic microscopic picture containing the malignant cells derived from the basal layer of the stratified squamous epithelium. As we see in this picture, is a stratified squamous epithelium giving the malignant cells. What's the criteria of the malignant cells? As we see in this picture, the nuclear cytoplasmic ratio increased, mostly of the cytoplasm containing a nucleus. Nuclear cytoplasmic ratio is increased, and in high power field microscopy there is mitotic figures, increased mitotic figures. But what is the characteristic of the microscopic picture of the basal cell carcinoma? This is the features of malignant cells in any malignancy. What's the characteristic of the basal cell carcinoma in the microscopic picture? The peripheral palisading appearance, which is surrounded by the red line. Palisading appearance, this is like this palisading appearance is like the wall of the garden. You know the wall of the garden? This is the wall of the garden which surrounds the malignant cells, as we see in this picture. This is called the palisading appearance of the basal cell carcinoma, and this is the characteristic picture of the microscopic picture of the basal cell carcinoma. It's a common MCQ question. What is the characteristic picture of microscopic of the basal cell carcinoma? Is palisading appearance. It's like the wall of the garden. Like the wall of the garden. This is the microscopic picture of the basal cell carcinoma. What's the treatment of the basal cell carcinoma? Basal cell carcinoma treatment is have multiple options. We have multiple options with the squamous cell carcinoma treatment. We have the physical and the medical. In the small lesions and early lesions, curettage and electrodissection, curettage of the lesion, or cryotherapy using frozen materials, cryotherapy, the early treatment of the earliest lesions and very small lesions. But the main treatment of the basal cell carcinoma is surgery, excision of the basal cell carcinoma. Excision of the basal cell carcinoma with a safety margin 0.5 inch in the skin of the body and 0.5 centimeters in the skin of the face. Surgical excision of the basal cell carcinoma is the main treatment, and it's the preferred treatment in small lesions and in large lesions. Small lesions and large lesions, the radiotherapy in the small lesions, we need no reconstruction of the skin. We close the skin primarily. In the large lesions, the radiotherapy, we need a large dose and 2 dimensions of the radiotherapy. So the surgery is preferred in very large lesions. In radio-resistant and radio-recurrent lesions, the surgery is preferred than the radiotherapy. So the surgery in small lesions, in the large lesions, in the radio-resistant and radio-recurrent cases, the patient should take radiotherapy of the basal cell carcinoma, and no response to the radiotherapy, the surgery is the best option. And the lesions near the eye or near the bone or near the cartilage, because the radiotherapy may destruct the eye or destruct the cartilage or destruct the bone. So the surgery is the best option in these lesions. We must know that the safety margin of the basal cell carcinoma is 0.5 inch in any part of the body except the face, which is the 0.5 centimeter is the safety margin. In some centers, the surgery may be micrographic Mohs surgery. Mohs surgery, which is a micrographic surgery, take parts from these lesions, small parts, and we examine the excised parts under the microscopy to see if it's containing malignancy or not. Removal the lesion, serial removal of the lesion by small parts, and the small parts are given to the pathologist to detect if it's free of malignancy or not, to avoid the larger safety margin, especially in the face. This is called Mohs micrographic surgery, removal of the lesion in small parts without safety margin, and examination of the ends by the pathologist during surgery to see it's free of malignancy or not. Medical treatment of the basal cell carcinoma may contain photodynamic therapy, which is a laser therapy. Photodynamic therapy, which other therapy give a amount of the laser to destruct the malignant cells, or tazotine. Tazotine is a third generation retinoic acid which is used for acne vulgaris, but have some results with the basal cell carcinoma, and imicimodium, which is Aldara cream, have a promising results with the basal cell carcinoma, but it's used also in small lesions of the basal cell carcinoma. So the main treatment of the basal cell carcinoma is surgery. We can summarize the basal cell carcinoma, basal P, by this mnemonics. Definition: malignancy of the basal layer, P, basal layer. The risk factors is ultraviolet B rays and albinism and xeroderma pigmentosa, P, basal cell carcinoma, P, derived from the basal layer of the epidermis, P, ultraviolet P rays risk factor, xeroderma pigmentosa, P is risk factor. The common sites: upper lip, P, above the upper lip, P. Histology: peripheral palisading appearance, B. Management: biopsy and pull it out with a safety margin, P. This is the summary of the basal cell carcinoma. The second common malignancy of the skin is the squamous cell carcinoma. Squamous cell carcinoma, or also called epithelioma or acanthoma or brachial cell tumor. As we said in the start of the lecture, the squamous cell carcinoma is derived from the polyhedral cells of the stratified squamous epithelium, which is called the brachial cell layer. So it's a brachial cell tumor. What is the etiology of the squamous cell carcinoma? Squamous cell carcinoma is caused by sun exposure. We say that the exposure of the skin to sunlight lead to malignancy. Even squamous cell carcinoma, melanoma, basal cell carcinoma, whatever the type of the malignancy, prolonged exposure to the sun lead to malignancy, especially in the white populations. What's the pre-malignant lesions of the squamous cell carcinoma? The most common pre-malignant lesion of the squamous cell carcinoma is solar keratosis. Solar is derived from the sun. This lesion is due to prolonged exposure to the sun. It's called actinic keratosis. Actinic keratosis, prolonged exposure to the sunlight, occur in old population, small, scaly, superficial lesions. Superficial lesion in the skin have scales. This is the most common pre-malignant lesion of the squamous cell carcinoma, actinic keratosis or solar keratosis. The second pre-malignant lesion of the squamous cell carcinoma is Poins disease. The Poins disease also is due to solar radiation or irritation by arsenics. Solar radiation from prolonged exposure to the sun, or arsenic. Arsenic in the patients who deal with arsenic in the factories. Arsenic lead to irritation of the skin and the formation of the Poins disease. Poins disease, also called carcinoma in situ. So, hyperkeratotic brown lesion of the skin, as we see in this picture, and surrounded with erythema. It's hyperkeratotic brown plaque, which is surrounded by erythema. The third predisposing factor of the squamous cell carcinoma is xeroderma pigmentosa. Xeroderma pigmentosa patients are poor patients. They are hereditary disease, which is autosomal recessive. This patient has extensive sensitivity to sunlight, with hyperpigmentation of the exposed parts of the body and atrophy of the skin and dryness of the skin, with ectropion leading to red eyes. These patients have a high incidence of squamous cell carcinoma and basal cell carcinoma and melanoma. Xeroderma pigmentosa are poor patients which have multiple pigments, have a high sensitivity to the sunlight, and have multiple pigments in the exposed areas to the sunlight, and dryness, ectropion, red eyes. They have a liability to any types of malignancy of the skin, squamous cell carcinoma, basal cell carcinoma, and melanoma. The fourth pre-malignant lesion of the squamous cell carcinoma is leukoplakia. Leukoplakia is a white plaques which occur in AIDS patients in the mucous membranes, and the mucous membranes lined by stratified squamous epithelium. The leukoplakia occur, leading to squamous cell carcinoma, especially in AIDS patients. Chronic leg ulcers or the scar. In poor patients with chronic leg ulcer, like varicose vein or scars due to burn, old scars due to burn, and prolonged ulcers or prolonged scars due to burn, this leads to what's called marginal ulcer. Marginal ulcer is a pre-malignant condition of the squamous cell carcinoma. It's high metastatic malignancy, but due to fibrosis, the fibrosis limit the extension of the tumor. When the tumor extend beyond, the fibrosis extend extensively. Chronic leg ulcers patients are poor patients which have a marginal ulcers. So marginal ulcer leads to squamous cell carcinoma. Lupus vulgaris is a TB of the skin. TB of the skin, which lead to chronicity, chronic skin lesion, and this chronic skin lesion leading to TB. It's called lupus vulgaris. The seventh lesion which leads to squamous cell carcinoma is papilloma. As we said in the last lecture, papilloma, especially papilloma of the anal canal, in the enoderm of the skin of the anal canal, the papilloma which is derived from the human papilloma virus, subtype 16 and subtype 18, is the pre-malignant lesion of the squamous cell carcinoma. يبقى papilloma which is derived from human papilloma virus type 16 and subtype 18, leading to squamous cell carcinoma. So the pre-malignant lesions of the squamous cell carcinoma is actinic keratosis, solar keratosis, Poins disease, and xeroderma pigmentosa. This is the three lesions due to sun exposure. Leukoplakia due to its chronic ulcers and scars, marginal ulcer, lupus vulgaris TB, and papilloma. This is the pre-malignant lesions of the squamous cell carcinoma. We must remember this lesions. It's a common written question. The pre-malignant lesions of the skin malignancy, squamous cell carcinoma, actinic keratosis, Poins disease, xeroderma pigmentosa, leukoplakia, chronic leg ulcers, lupus vulgaris, and lastly, the papilloma, human papillomavirus type 16 and type 18. What are the types of the squamous cell carcinoma? Squamous cell carcinoma has a multiple types, but the most common two type is the nodular type, which is the earliest lesion of the squamous cell carcinoma. We have a nodular type, which is the earliest lesion of the basal cell carcinoma, and the ulcerative type. Ulcerative type have a criteria of the malignant ulcer. As we see in this picture, the ulcer is raised everted edges, necrotic floor, and indurated base. This is the malignant ulcer. Malignant ulcer, the description of the malignant ulcer typically is raised everted edges, indurated base, and necrotic floor. This is the typical type of the malignant ulcer. Unlike the basal cell carcinoma, the edges are rolled in beaded edges. The squamous cell carcinoma raised everted edges and indurated base. As we see in this poor patient who have chronic leg ulcers, this chronic leg ulcer lead to malignancy, margarine ulcer, which is converted to squamous cell carcinoma, raised everted edges, indurated base, and necrotic floor. What's the microscopic picture of squamous cell carcinoma? We have two types of squamous cell carcinoma, differentiated and undifferentiated. Differentiated is meaning that the tumor or the malignancy is near its original type, near its original tissue. Undifferentiated meaning that the tumor is away from the normal tissue. The normal tissue of the skin, stratified squamous epithelium, have a keratin. This keratin is formed of the stratified squamous epithelium. So the differentiated subtype of the squamous cell carcinoma have a keratin. At its center, as we see in this picture, the keratin in the red color, this is like the nest of the bird. So it's called cell nest. The nest of the bird is like this, the keratin in the center, and surrounded by the malignant cells, which is malignant cells. As any malignant cell, mitotic figures increase nuclear cytoplasmic ratio, increase the size of the nucleus, and whatever, etc. As a signs of malignancy in the cells. But the characteristic of the squamous cell carcinoma is the keratin, cell nest, keratin in the center, which give the picture of the cell nest. This is a differentiated type. As we see in this undifferentiated type, away from the original type of the original tissue type of the squamous cell carcinoma, this malignant cells, undifferentiated type, have no keratin, no cell nest. Malignant cells without central keratin. If we go to the picture, we may see that there is a spots of keratin, red color, but no cell nest. Away. The malignant cells are away from the normal tissue. This have a bad prognosis. Squamous cell carcinoma with a bad prognosis in undifferentiated subtype. What's the treatment of the squamous cell carcinoma? The treatment of the squamous cell carcinoma is like the treatment of the basal cell carcinoma. The surgery is the main treatment of the squamous cell carcinoma, but we must have a safety margin at least 1 inch. Remember, the basal cell carcinoma, the safety margin is 0.5, half inch. In squamous cell carcinoma, the safety margin is 1 inch. In the face, it's 1 centimeter. Mohs micrographic surgery, serial excision of the lesion, and sent it for the pathologist to detect it's free of malignancy or not. If it's free of malignancy, we stop the surgery. If it's not free from the malignancy, we continue with the dissection of the malignant cells reaching the healthy tissue. We don't need a safety margin. We confirm that the tissue have no malignancy by histopathology. This is called Mohs micrographic surgery. What's the indications of surgery? As we said, small lesions, large lesions, radiocurrent, radioresistance, lesions near the ear, near the eye, lesions near the cartilage due to fear of destruction of these tissues by radiotherapy. The medical treatment may include photodynamic therapy, tazortine or imiquimod, Adalara cream. So the treatment of this squamous cell carcinoma, to summarize, the squamous cell carcinoma raising from the precursor layer of the stratified squamous epithelium, we have a multiple premalignant lesions. The common factor in this premalignant lesion is sun exposure, actinic keratosis or Poins disease, or xeroderma pigmentosa, which is an autosomal recessive disease, leukoplakia from the age, chronic ulcers and scars, lupus vulgaris, which is the TB of the skin, and papilloma, human papilloma virus type 16 and type 18. We have two common subtypes of squamous cell carcinoma, nodular subtype and the ulcerative subtype. The ulcer is typical malignant ulcer, is deviated edges, indurated base, and necrotic floor. Microscopic picture, differentiated and undifferentiated. Differentiated containing keratin at its center. The characteristic is cell nest. Undifferentiated have no central keratin. Treatment of squamous cell carcinoma surgery is the main treatment with a safety margin 1 inch in the face, 1 centimeter, maybe Mohs micrographic surgery in the face, radiotherapy, and medical treatment in very small lesions. This is the squamous cell carcinoma. The third type of malignancy, which is common in the skin, the melanoma. Melanoma also is due to sun exposure. As we say, the melanoma is derived from the melanocytes which is the pigmented cells of the skin. The melanoma is caused by sun exposure as any type of the malignancy of the skin. Artificial ultraviolet rays sources, common in white population with fair skin, freckles, and red hair. It may be hereditary, familial, atypical. Familial atypical multiple mole melanoma syndrome. Pre-malignant lesions of the melanoma are junctional melanomas, compound and blue nevi, xeroderma pigmentosa. Junctional and compound and blue nevi, as we said in the last lecture, simple mole is not pre-malignant. Junctional, compound, blue nevi is the pre-malignant lesions of the melanoma. Xeroderma pigmentosa, which is a universal pre-malignant lesion of the skin. So in the exam, if we don't remember any pre-malignant lesions of the skin tumors, we have two pre-malignant lesions: sun exposure, xeroderma pigmentosa, universal predisposing factor of the malignancy of the skin. Any type of mole is a melanoma, is a malignancy? No. The melanoma have a ABCDE criteria. A, asymmetrical edges. Symmetrical edges of the lesion indicate malignancy. Borders is irregular, notched, or blurred, indicate malignancy. Color of the lesion is mixed color, not a unicolor, indicate malignancy. Diameter more than 6 millimeters, indicate malignancy. E, evolving over the time, increasing in size, change in color, indicate malignancy. Other indications or other signs like falling of hair, ulceration, or other types of signs which indicate malignancy of the melanoma. A, B, C, D. E, A, asymmetry. B, borders. C, color. D, diameter. E, evolves over the time. We have main four types of the melanoma. Superficial spreading type, which represent 65% of the cases. As we see in this picture, the lesion is large lesion, more than 6 millimeters. A, asymmetrical lesion. B, borders are irregular with notches. C, color is mixed. Diameter D is larger than 6 millimeters. This is all the indications of the malignancy. This is superficial spreading lesion. Nodular subtype of the melanoma. As we said, in the basal cell carcinoma, there is nodular subtype. In squamous cell carcinoma, there is nodular subtype. In the melanoma, this is a nodular subtype. Nodule. This nodule is raised over the skin and have a black color and grow vertically. Raised spot, dark or light, and grows vertically. One type of the melanoma which have a bad prognosis is acral lentiginous melanoma. Acral lentiginous melanoma occur mainly at the palm and the sole and subangual, under the nail, subanguals under the nail. Have a bad prognosis. Type of melanoma with delayed diagnosis and have a bad prognosis. Lentigo malignia. Lentigo malignia, we remember that the Hutchinson's freckles. Hutchinson's freckles are the pre-malignant lesion of the lentigo malignia. Hutchinson's freckles are the freckles which occur in the old population. Hutchinson's freckles is a pre-malignant lesion and lead to lentigo malignia, which is the malignancy of the Hutchinson's freckles. But lentigo malignia have a good prognosis. The fifth subtype of the melanoma, which is very rare subtype, is amelanotic melanoma. This lesion is devoid of the color of the normal melanocytes. It occurs mainly at the mucocutaneous junction, especially at the anal canal. The amelanotic melanoma have a very bad prognosis because the cells are away from the normal tissue, are very away. The normal tissue is pigmented, while amelanotic melanoma is not pigmented. But it may give melanotic secondaries. The secondaries may be have a melanin color. What's the microscopic of melanoma? As we said, it's melanoma have two types, melanocarcinoma and melanosarcoma. In both types, there is malignant melanocytes. These malignant melanocytes are pigmented cells with malignancy. Pigmented cells with malignant criteria, increase in nuclear cytoplasmic ratio, increase the size of the nucleus, and increase in mitotic figures, the signs of malignancy. Pigmented cells, as we said, at the basal and the dermis, under the epidermis of the skin. This is the melanocytes, which is malignant melanocytes. If the cells is circular or spherical or polyhedral, it's called melanocarcinoma. If the cells are spindle shaped, it's called melanosarcoma. But the cells are malignant pigmented cells. The melanoma is a highly metastatizing malignancy, which may give spread to the lymphatic system, lymph nodes of the draining lymph node of the affected organ may be enlarged in melanoma. So we must examine the affected organ lymph node drainage, like in the lower limb, inguinal lymph node, upper limb, axillary lymph nodes, head and neck, the upper and lower deep cervical lymph nodes. Also, the melanoma may spread to the lung, to the brain, and to the bone and to the liver, and may give to melanuria, melanin excreted in the urine in heavy metastasis cases. What's the staging of the melanoma? It's an important topic to stage the melanoma. The old staging system is the Clark levels of the melanoma. The Clark levels of the melanoma. In level 1, the malignant cells don't invade the basement membrane of the stratified squamous epithelium. In level 2, the malignant cell invade the basement membrane but doesn't fill the dermal papillae, as we see in this picture. Level 3, malignant cells infiltrate the junction between the papillary and the reticular dermis. The upper layer of the dermis is called the papillary dermis. The lower layer is called the reticular dermis, as we said in the last lecture. In level 4, malignant cells invade the reticular dermis, the deep layer of the dermis. In level 5, invasion of the subcutaneous tissue. So we have 5 levels in the Clark staging. The Perslow depth of the melanoma is accurate more than the Clark staging. Perslow detect the level of invasion by millimeters. If it's less than 1 millimeter, it's stage 1 Perslow or level 1. Level 2, 1 to 2 millimeters. Level 3, 2 to 4 millimeters. More than 4 millimeters is level 4 of Perslow depth. What's the importance of Perslow depth? The importance of Perslow depth of the melanoma is the detection of the safety margin. In level 1, the safety margin of melanoma is 1 centimeter. It's enough. In level 2 and 3 of Perslow depth, 2 centimeters is enough. In more than 4 millimeters depth, level 4 Perslow, the 3 centimeters is a must. Safety margin of the melanoma is 3 centimeters. So the safety margin of the melanoma is detected according to the Perslow depth. The Perslow depth. The pathologist, when we take a biopsy from a melanoma to diagnose it as a melanoma, we must take full thickness to detect the Perslow depth. The pathologist must say the depth of the tumor. 1 milli, 1 to 2 milli, 2 to 4 milli, and more than 4 milli. Level 1, level 2, level 3, level 4. Level 1, 1 centimeter is safety margin enough. Level 2 and level 3, 2 centimeters are enough. More than 4 millimeters, which is level 4, 3 centimeters is a must safety margin. Also, the prognosis of the melanoma is detected according to the Perslow depth. What's the treatment of melanoma? Wide local excision with a safety margin, as we said, according to Perslow staging system. Plus lymph node dissection if present. If the lymph node is palpable or detected by ultrasonography or CT scan, the lymph node must be dissected. Removal of the lymph node. As we said that the tumor is highly metastatizing tumor. Highly metastatizing tumors, especially to the lymph node. So lymph node dissection is indicated in the cases when the lymph node is enlarged. When the lymph node is enlarged. Chemotherapy may be given to the inoperable cases or recurrent cases or in transient metastasis. We give vincristine, melphalan, but melphalan is highly toxic. So we may give it by isolated limb perfusion. What's the isolated limb perfusion? A tourniquet is applied to the limb and an extracorporeal circulation is established with a pump and oxygenator. By this method, the melphalan used in high dose with little or no systemic side effects. We tourniquet around the limb and an extracorporeal machine establish the circulation like the heart-lung machine in the open heart surgery. Extracorporeal circulation is established by this pump to give oxygen to the limb, and the melphalan is injected by a high doses with no systemic side effects to the affected limb to avoid recurrence of the tumor. Immunotherapy like interleukin-2, interferon, and the BCG vaccine give a good results in some cases of melanoma. Prognosis of the melanoma. Prognosis according to Perslow thickness. In situ melanoma, carcinoma in situ, 5-year survival rate is 90 to 100%. Less than 1 millimeter, stage 1, 80 to 90%, 5-year survival rate. 1 to 2 millimeters, depth 70 to 8%, 2 to 4 millimeters, 60 to 70%. If it's more than 4 millimeters, it have a bad prognosis, 50%. The type of the melanoma also give the picture of the prognosis. We said that the amelanotic melanoma have a bad prognosis, very bad prognosis. acral lentiginous melanoma have a very bad prognosis because it's delayed diagnosis. A melanotic melanoma is away from the normal tissue. The site of the tumor also give a picture about the prognosis. Melanoma of the limbs are more favorable prognosis than that of the trunk. So we must summarize the melanoma. Melanoma is the tumor of the melanocytes. What the melanocytes? The pigmented cells of the skin. The predisposing factor is sun exposure and zero dermapigmentosa, the universal predisposing factor of the skin malignancies. Junctional compound and blue nevi, familial melanoma syndrome, white population and artificial ultraviolet sources. The ABCD of melanoma: asymmetry, borders irregular, color is mixed, diameter is larger than 6 millimeters, evolving mole. We have 4 main subtypes: superficial spreading type, nodular melanoma, acral lentiginous melanoma, and lentigo malignia in top of Hutchinson's freckles. The most common is superficial spreading subtype. A melanotic melanoma occur mainly at the mucocutaneous junctions, especially at the anal canal. A melanotic melanoma have a very bad prognosis. Microscopic picture: malignant pigmented cells, maybe melanocarcinoma in spherical or polyhedral cells, melanocarcinoma, melanosarcoma in spindle-shaped cells, melanoma metastatized to the lymph nodes, liver, lung, bone, brain, and may give melanoria in heavy metastasis. Staging mainly to Perslow depth system. Perslow depth system level 1, less than 1 millimeter in depth of the epidermis, 1 to 2 millimeters in the dermis, 2 to 4 millimeters in the dermis, more than 4 millimeters in the lower part of the dermis and subcutaneous tissue. Perslow depth is better than the Clark. According to Perslow, we detect the safety margin and detect the prognosis. Level 1 centimeter safety margin is enough. Level 2 and level 3, 2 centimeters is enough. Level 4, at least 3 centimeters. Treatment: wide local excision with or without lymph node dissection according to the presence of enlarged lymph nodes. Chemotherapy: we must not forget the isolated lymph therapy because melphalan is highly toxic. Immune therapy give good results in some cases, like the interferon and the BCG vaccine of the TB. Prognosis according to Perslow thickness. And thank you.